Hi, welcome to an in-service on postpartum hemorrhage. I put this together for staff that are newer to the unit and especially those that are working on mother-baby. My name is Donna Grothwall and I've worked here at Elkhart General for 36 years. I also work for Southwestern Michigan College as a clinical instructor here in maternity. So there's two reasons I put this in-service together. One is because as nurses, of course, we want to provide the best nursing care that we can to our patients. And then second of all, there's a conversation being held across the United States on how we can improve the maternal mortality rate. And as you can see by this slide, when you compare the United States against other developed countries across the world, you can see that our numbers have gone up, whereas other countries, their numbers have gone down. When you talk specifically about the United States, there are 3 states here in darker red that are at the highest for maternal mortality rates, and unfortunately Indiana is one of them. Georgia is the top, then Louisiana, and then Indiana. As you can see to the far left, California and Nevada are 2 of the lower states. And then when you look at Indiana's rates back in 2016, you can see in the red bar where Indiana stands, and then the blue bar is the United States as a whole. And Indiana has twice the numbers that the United States does. The reason I pointed out California is because they have made major strides in decreasing their rates. And you can see back in 2006, they had a spike, and so there were people that started to look at this, physicians, anesthesia, nurses, and wanted to see what they could do to decrease their rates. So they looked at hospitals and saw, who had the lower rates, who had the higher rates, and what were the hospitals doing that had the lower rates. They looked at evidence-based practice and developed protocols and put those into action across the state, and you can see then that their numbers decreased quite rapidly. They actually decreased their numbers by 55% during the years of 2006 to 2013. And they developed what's called the California Maternal Quality Care Collaboration, CMQCC, and now they're being looked at, and their protocols are being looked at across the United States, and I'm sure in other countries of the world, to see what they, because they're who we strive to be. And so we're following their protocols, as are many hospitals across the country. And actually, we're being expected to do that. We have to submit statistics. JCO, when they come in to do a survey, they're looking for these protocols being used as part of their survey of the unit. So, postpartum hemorrhage is the leading cause of mortality worldwide. Number 2 is infections, and then number 3 are the hypertensive disorders. And although this says 2 to 6% of women suffer some degree of postpartum hemorrhage, I've read that it's as high as 10%. So fortunately, a woman's body, is set up in an amazing way, so that women, as part of their changes of pregnancy and in anticipation of natural blood loss at birth, increases the plasma volume to approximately 40% or 50% more than what they have when they're not pregnant, and then the red blood cell increases about 25%. When there is bleeding after birth, if you think about it, the once the placenta is delivered, there are all kinds of vessels that are wide open at this point. So, in order to take care of that, there's contraction of the myometrium of the uterus, and what it does is constrict those blood vessels that used to supply the placenta. And with further blood loss, it ends up in tissue hypoxia if that bleeding goes on, and it results in an anaerobic metabolism, and there's production of lactate with resultant lactic acidosis, which goes on to kill cells. So the definition of hemorrhage by ACOG, which is the American College of Obstetricians and Gynecologists, they define it as a postpartum hemorrhage with a cumulative blood loss of greater than 999 cc's. That blood loss can be accompanied by signs and symptoms of hypovolemia within that first 24 hours following birth. And once we get to a blood loss of 500 cc's, that alone should trigger increased supervision and potential interventions. So there's both early or primary postpartum hemorrhage and late or secondary postpartum hemorrhage. Early is within that first 24 hours after delivery, with the first hour being the time most at risk. And about 80% of these women will have uterine atony, where the myometrium of the uterus is not contracting enough to depress those blood vessels where the placenta was. They also may have what's called retained placental fragments, where even if small fragments are left in the uterus can't contract like it normally does. There is placenta accreta, and then there's placenta percreta and increta. And what this means is that the placenta has embedded even more deeply into the uterus than what's normal. And so that placenta just doesn't want to pull away. And although sometimes they know ahead of time, sometimes they don't. And these patients can end up needing a hysterectomy depending on how much it has embedded. The patient may have defects in their coagulation. Uterine inversion is where the uterus actually comes out of the vagina, and when it pulls out like that, then it goes inside out. And I've never personally seen this. We do have these occasionally, but it can cause a great deal of blood, and it could be caused from too much traction being put on the cord as the placenta is being pulled on. It could be due to a short cord. It could be from excessive fundal massage, where there's a lot of pushing going on the fundus of the uterus, and that's why it's good to have a second hand supporting the bottom of the uterus so that this doesn't happen. Patients can also have hematomas, and we're not going to see as much blood with this, but it does cause a lot of pain and pressure for the patients. And so when that happens, we look to see if we can see a hematoma, and they're usually quite, they feel, firmer, and those sometimes need to be evacuated. Causes for late postpartum hemorrhage, which occurs greater than 24 hours and less than 6 weeks postpartum, could be due to infection. Again, the uterus, the subinvolution just means the uterus isn't contracting as it should, retained placenta fragments, and coagulation defects. There are many risks for postpartum hemorrhage. Maybe they had a history of this with a past pregnancy, family history, and their mothers, sisters, and close relatives. It could have been a traumatic delivery with lacerations or a hematoma. fibroids, patients who have a precipitous labor and birth, prolonged labor, patients that are induced, especially with Pitocin, if they get, maybe they're in labor for a couple of days with Pitocin and just get a lot of Pitocin, then the uterus is kind of wore out when it comes out and doesn't want to contract as much. Operative vaginal birth would be those who had had a forceps or suction delivery. Uterine overdistension, perhaps they had twins, perhaps they had polyhydramnios. And then you can see the rest of them, a uterine rupture where, of course, the uterus can rupture if they have low platelets to begin with. The drugs I talked about, like oxytocin, but also if they've been on max sulfate. And what's interesting to note, though, is more than 50% of women with uterine atony have no risk factors at all. So we do postpartum hemorrhage risk assessments in labor. It's a tool, again, from that CMQCC, where we are doing an assessment at admission. We're supposed to be doing one 30 to 60 minutes prior to delivery, within 60 minutes after delivery, and then you've seen those where we do them Q shift also. So the best way to measure the amount of blood loss is to actually quantify it. And what we'll do is measure it. We'll measure sponges, we'll measure peri-pads, chucks, and wherever that blood is, so that we can get an accurate measurement in cc's as to what they've lost. If we have a hemoglobin and hematocrit from prior to delivery, which we almost always do, we can also look to see how much it's decreased. And for every 3% drop in the hematocrit, there's been a blood loss of 500 cc's. Or the hemoglobin has dropped 1 to 1.5 grams. But again, this is an estimate, and the best way is to actually weigh the blood. Keep in mind also that the hemoglobin and hematocrit, depending on when it was done, may not be reflective of what's currently gone on, especially if they've gotten large amounts of fluid. Their blood is going to be have more fluid in it sometimes, and so it's not going to give us an accurate reading. So, if we do it at that time or 30 minutes after, we're not going to have an accurate value. This is another, this is just a board that was done by one of our staff members that shows how we quantify blood loss. We used to do an estimated loss, but it wasn't reliable and was usually way under what actually was lost. And then 1 gram equals 1 ml. We have a little chart on our hemorrhage cart, if you haven't already seen it, that lets us know like how much a sponge weighs. So as you might be able to see in this picture, a sponge weighs 18 grams. So we'll weigh the sponge, say it weighs 90 grams. We're going to subtract the 18 for the sponge itself and record 72 cc's of blood loss. And then we have measurements for peri-pads and chucks and so on. So this is one of the tools that we use to help us decide what needs to be done based on the amount of blood they've lost. And I know this is hard to read, but through the green, our top green there is stage 0, where they've lost some blood, but we're not at 500 cc's of blood loss yet. So we're having some increased bleeding, and we want to be aware of it, keep an eye on it, and keep quantifying it so we know how much they've lost. Stage 1 then is a blood loss greater than 500 cc's up to 1000 cc's. And of course, the charge nurse needs to be notified. We will probably notify anesthesia. Vitals should be done every 15 minutes. We'll continue to measure and weigh for blood loss. We're probably thinking about doing a second IV at this point. Type and cross will be done, and then we can give medications as the physician orders it. And we're kind of thinking about what is causing this blood. Is it uterine atony, or is it a bright? If you have a firm fundus but still having bleeding, usually bright red blood, it could be due to laceration. So we kind of start thinking about what has caused this. Stage 3 in the orange is a blood loss greater than 1,000 but less than 1,500 cc's. Again, thinking about medications, doing more labs, and notifying the blood bank that we are probably going to need some blood to give to the patient. And then the worst stage is stage 3, when we have a greater than 1,500 cc's of blood loss. And this is where things are getting even worse. And they're definitely going to need blood products, meds if we haven't given them yet. We have everybody involved and are working to decrease that, to decide what's going to be done next. These are the normal signs of blood loss, and you can read through those. But just keep in mind that hypotension may not occur until there's a blood loss of 10 to 30% of total blood volume. So that's not going to be one of the first signs that we see. Another tool that can be used is the mean arterial pressure. And this may be a first blood pressure response to hypovolemia. And you can see the formula and an example of how you figured that out. And if it's decreased to 30 millimeters or less, then we know there's been a substantial blood loss. As the blood loss gets more excessive, then we have more symptoms that we might see. We'll have a very restless patient who's confused about what's going on. They may faint even when they're laying in bed. So MUSE is the maternal early warning signs. Forget that first early on there. I don't know how that got there. But anyways, any of the criteria on the left needs to be immediately communicated to the provider. And then in the second column, those are numbers that if we see, then we need to repeat within 10 minutes and then call the physician and let them know what's going on. There are different medications that we will use during this time. First line med is always the Pitocin. It's a natural hormone that you produce in your body, but of course what we use is a synthetic form of it. We use it to induce labor. It's considered a high alert medication, but that is primarily during labor because patients need such little amounts of Pitocin, whereas after delivery they're getting much larger doses. But then after delivery, of course, the body uses Pitocin to contract that uterus. And so we use a greater amounts of that. And we have pre-mixed bags in the drug machine. Another med that would be used is Methergin. And this affects the smooth muscle of the uterus. And it increases also helps to increase contractions. This medication is only given IM. Although it can be given IV, there's a much increased chance of hypertension or stroke with it, so we give it IM. It can be given every 2 to 4 hours, but because it causes hypertension, it's not going to be used in a patient with extreme hypertension. I've seen them give it in a patient who has, their blood pressure has slightly increased, but not with somebody who has hypertension and has high blood pressure. Hemabate is another drug, and it's a prostaglandin, and that medication is given IM. Sometimes you'll hand it to the doctor, and they will inject it directly into the uterus. But they can have this every 15 to 90 minutes, and it's contraindicated in a patient who has asthma. Cytotec is also a frequent drug. This might be second in line to give. It just depends on the physician. But it's going to be given 800 to 1,000 micrograms, usually rectally, and it can also be given orally. As you may know, we have a postpartum hemorrhage kit that we get out of the drug cabinet, and it's already filled with all of these medications except for the TXA. But if you're going in to pick out a specific drug, keep in mind that the Cytotec is in there in 100s micrograms and in 200 micrograms. We use the 100s for when they're in labor, and then we use the 200 micrograms for a postpartum hemorrhage. Tranexamic acid, or TXA, is a med we've just been using within the last couple of years. And it's not really affecting the hemorrhage as much, or it's not making the uterus contract or anything like that. But the way it can reduce bleeding is it helps to break down like fibrin blood clots so that we don't get into trouble with those. And we can give this 2 times. The first gram is given within 3 hours, and it is mixed by pharmacy in a 50 cc bag, and that's given within 10 to 15 minutes. We should be giving it, the amount of time it takes to give is between 10 and 15 minutes, and then it can be repeated 1 time in 30 minutes after the first dose is given. All right. So these patients need timely identification, and there are times where they get through, that immediate hour, they get through their next hour or 2 of recovery time, and then all of a sudden they'll start bleeding. So, always know that you can do more checks than you need to, or what we're supposed to do. But if they have been bleeding more than usual during their recovery period, then vital signs and fundal checks should be done more often. And if bleeding does appear to be excess, that's where you call for some help. The charge nurse needs to be notified right away so that they can be of help and resource to that. And then they'll take care of, or they'll make sure that the physician anesthesia has been notified. And so excessive bleeding would be saturating a peri-pad in 15 minutes. These patients, especially if their uterus goes boggy pretty easily, they need continual fundal massage. But just know that excessive massage can tire those muscle fibers out and have the opposite effect that you want. I talked to already that the bright red bleeding with a firm uterus can be a sign of lacerations, or maybe the episiotomy is bleeding. And sometimes they just have a big old clot up there that needs to come out. You'll have your small ones, and you can have really big ones also. If the hemorrhage cart isn't already at the bedside, it should be moved there and the scale moved, or just bring it into the room, get the scale out, and one of the people in there should be measuring. And sometimes the patient just needs to void. So if you have a uterus that's deviated to the right and it's, above the umbilicus, then they probably need to void. And if they're having a pretty good hemorrhage at that point's not a good time to get them up to the bathroom or seated on a bedpan. So a Foley catheter is usually placed. So somebody could grab the postpartum kit from the drug fridge, and having those drugs, in front of somebody ready to pull out. That postpartum hemorrhage kit has syringes, needles that are needed, and it also has information on the outside of the bag that reminds, like Methogen should be given IM, shouldn't be given to somebody who has hypertension. So try to make it easier for people so that they have that information in front of them. The patient's head of the bed should be down and their legs should be elevated 20 to 30 degrees so that we're helping to increase venous return. IV fluids are probably going to be run wide open for a while. And if somebody can get the second IV supplies that are needed and ready, a lot of times anesthesia will put that in for us. Of course, blood pressures need to be going, Q15, they need a SAT monitor, and they may need some heart monitoring also. Patients can be cold during this time because not only are they losing blood, but the bottom half of their body is not being covered up. So getting some warm blankets and putting them around their head or across the top of their body are helpful. They may need some pain management because of all the pushing that's being done. Maybe, they do have that hematoma, and that's going to be uncomfortable for them. And then they also need a lot of emotional support, as does their family. A Bakri is a balloon tamponade that the physician will put up into the uterus, and then there's syringes that we fill up with sterile water, and then that water is pushed in to expand that Bakri, and those are very good at making the vessels not bleed as much. They're going to need some labs done. We need to be ready to do a blood transfusion. And somebody needs to be writing down everything that's being done. So even though this may be your patient, but the things that are being done may be done by labor staff. You can pick out some things in here that you're able to do to help, like getting the warm blankets, getting the hemorrhage cart, making sure their blood pressure cuff is on, the SAT monitor is on, being that emotional support, and maybe you could record what's going on. So what's next? I already talked about the physician placing the Bakri. They may need to go back to the OR for a DNC. Maybe they do have those placental fragments. Maybe we need to take them back to the OR, and anesthesia might need to give them some sedation so that a doctor can look at a hematoma or other things. More and more we're sending patients to interventional radiology for an embolization. And then the worst procedure then would be the hysterectomy. This is just, I thought, some interesting information on packed red blood cells versus platelets versus FDP or cryoprecipitates. And I'll just mention, like the packed red blood cells, there's usually 240 cc's in a unit, and it could be expected to increase the hematocrit by 3 percentage points and increase the hemoglobin by 1 gram. And it contains RBCs, WBCs, and plasma. Of course, that they continue to lose blood, we may not see those increases in the hemoglobin and hematocrit. So that's the end of my presentation. I hope that you found this informative. And, knowledge is power. So anything you can learn about these things, listen to other nurses as they talk about these topics so that you can learn more and more. And if you have any questions, be sure to ask. Physicians will answer questions, or other nurses, or shoot questions to myself. So I appreciate your time as you watch this, and that is all. Thank you.